right, I would go back and look at most common eight-phasic, most common finding in eight-phasic patient, which is anomia. Take a look at your cerebral signs. Take a look at your major inhibitor of the spinal cord. Take a look at Baroque's, Wernicke's, I think we talked about those. Take a look at your folic acid recommendations. Is this the right class? Am I in the right place? Am I really?
You're talking really fast.
You're getting after some
Okay, take a deep breath. Right. I feel like I'm going fast. I'm going fast. Pretty fast. All right. You really need me to do that again? I can. All right. Most common finding in aphasic patients being anomia. Yeah. Cerebral signs, specifically apraxia and neglect. Got it. Major inhibitor of the neurotransmitter of the spinal cord. Did I remember it? Just look it up. Take a look at Baroque's, Wernicke's, the anatomy portion of it. So also we kind of compared them side by each. Do you guys remember that? Let's take a look at it again. Good. Okay. Folic acid recommendations. You there? Okay. And then I have that. I don't know if this might have been from the first lecture, but go back and look at C8. It's have C8 motor and reflex function. So I don't know what happened there. Maybe I was driving and had a thought. Maybe I'll ask a question about that. And then anencephaly, which is failure of the anterior neural cord to close. Take a look at that one. That one was in there too. Is that better? Okay. Thanks. Yeah. Maybe they put something extra in my coffee. We're going fast. It's a little crack, is that what you said? Crack is wet. All right. Disease of the nerves. Disease of the nerve. Nerves. So what do you guys think about when you think of neuropathy or disease of the nerve? Parkinson's disease? MS? Diabetes? Yeah, diabetes. Talked about that a little bit already. So, what is it? Demyelination? Good. Man, you took it back to some anatomy stuff. That's good. Schwann cells? Nice. Yeah. You're not wrong. It's going to pop up here in a second, so you're going to be very happy you said that. You're going to be like, yes! My favorite. What else? Nothing? No. I don't know, I just hear like yelling. Guillain-Barré, okay. I heard Gillenberg. I'm like, old Gillenberg. Yeah. Yes, Guillain-Barré syndrome. Absolutely, that is a good one. We'll talk about that a little bit. So, do you guys think? All right. So aside from just kind of having you guys yell out things, do you think you're going to see this at all? Yeah. Active duty first. You guys think you're going to see neuropathies? Post-trauma. Post-trauma. What else? Carpal tunnel. Absolutely. Anybody have it? Yeah. Kind of sucks, right? Like your hands, you're always doing this. You're like, what's going on with my hands, right? Yeah, absolutely. So spinal cord stuff like herniated discs, foraminal stenosis, you said cervical lumbar impingement. Absolutely, all that good stuff. Which if you have that too, like you can get radiculopathy or numbness tingling down your legs. That's exciting. What else might you see? I think you'll see, someone said MS, think you'll see MS? Potentially. Yeah, once or twice I've seen it active duty. Usually like headaches, visual changes. Not responsive to therapy, you go back and image them and they come back with all sorts of gliotic formations and you're like, oh, that's probably a reason why you're having headaches and visual changes.
Are you guessing the disease?
What's up?
Are you guessing
Extrapyramidal symptoms? Yeah, it can be. Yeah, absolutely. Yeah. All right, let's jump. We'll go through this thing, and then we'll talk about it. We'll digest it and see how we feel, and then we'll go from there. I'll see if you guys, I'll say what I have to say and see if you like it. If not, I don't know, try to make it a little bit better. But what's after me? Ortho? Ortho and then EKG?
That's farm.
Then farm at the end of the day?
No.
Farm and EKG.
Okay. That's not too bad. That's a great, that's just, boundless opportunity to win. So. All right, TLOs, ELOs, same thing. A little bit of anatomy in the front. You guys got kind of a bunch of anatomy yesterday, so some of this is redundant, and that's fine. So 31 pairs of nerves, spinal cord, right? Just 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, 1 coccygeal nerve. And again, just kind of knowing your anatomy, going back to where your patient's having some issues and then chasing them upstream. I do this all the time. My patients come in all the time, and they say like ER or active duty, and they're having like bilateral upper extremity numbness and tingling, right? And I'm kind of chasing it back, and I'm working that anatomy. It's not their hands, it's all the way from their neck down. Maybe I think, okay, so they got something in their cervical neck pinching a nerve, creating a problem. So you guys are going to be constantly going back to baseline anatomy, trying to figure stuff out. So if you don't have a good feel about that, I'd say kind of keep looking at it and get more comfortable with it. All right, you guys remember these? Sensory dermatomes? Yeah? Does everybody got it memorized? Does everybody get at least T4 and 10 memorized? Yeah. Those are T4s all day, right in the face. Yeah. Those are quick, down and dirty and easy. And you guys will get familiar with these when patients come in and they say, herniated discs, usually in the lumbar spine, right? And it's causing pressure, usually L5, S1, but you chase it down. You say, where does it go, right? Does it go to your knee? Does it go to your foot? What part of your foot? And then you start thinking about your dermatomes. You're like, yeah, maybe he's crunching a nerve somewhere, or he or she. So, and these are just going to help us aiding and localizing neurological lesions, right? Just like we said. And a quick down and dirty for like rapid trauma assessment too. So if you guys are doing a rapid trauma assessment, polytrauma, and you need to see if someone's intact at T4, T10, you guys know what to do. You can do a painful stimulus there. So yeah, they're grossly intact. So yeah, that gets you 2 points on that test. So I'm not supposed to teach you the test. What can I do? What can I say? All right, anatomy of a nerve cell. Everybody remember this? All right, axon dendrites. You remember this? Kind of looks like an alien. It's everybody's favorite cell, at least for right now. All right. So just some anatomy stuff. I'm not going to ask you the questions on this about, what is a dendrite, what is an axon, but just understanding how this nerve receives and propagates signals is going to be important in understanding some of our pathology as we navigate through this. So what the axon is, pause for effect, let's read it. I want to wait for you. Good? All right. All right, and then the connection between the two synapses, so like what happens between these cells, how do they talk to each other? Do you guys remember? ACH. Acetylcholine, what else? What else is important in this nerve propagation? Maybe a little sodium, a little calcium. Yeah, little good stuff like that, so yeah. And you guys love that stuff so much, I would kind of talk about it real quick here. So this is just going over kind of what happens, right? So yes, I will read this out loud to you guys, not to insult anybody, but just so we are all on the same sheet of music. So nerve impulse arrives at the synaptic end, bulb of a presynaptic neuron. After that, depolarization phase. I'll let you guys read the rest of that. Increased intercellular calcium level, right? Triggers exocytosis. That's a tough one for me, guys. Neurotransmitter molecules diffuse across the synaptic cleft, right? And then ligand gated channels open. This is where our sodium comes into place. And then we have depolarization potential, right? So you guys don't even think about that happening, thank God. Mine would be a little bit busy. You guys got farm, CHF, stuff to think about. Think about all this stuff happening, which is great. So what? Why do we talk about all that? Clinical correlation. You guys think you're going to use lidocaine and marcaine at all? Have you guys talked lidocaine and marcaine at all? Yeah. So all it is it's a sodium channel blocker. So what's some indications for using this? If I want to numb somebody up. Dental block. Did you guys do dental blocks already? Is that fun? Is that a fun day?
A lot of trust.
Yeah, a lot of trust. Did anybody go did you guys do inferior alveolar block? You went up front too? Did anybody go up into the nasal cavity? No? You're like, how the hell did you do that? Yeah. I've done it. I've done it on one of my, I did like an inferior alveolar. So first of all, dental blocks are great. Odontalgia sucks. Like tooth pain, if you ever had it. And so a lot of my meth addicts have terrible dentition. So they come in and they have tooth pain, and I believe them because their teeth look terrible. So you can do a bunch of things when you're treating pain. You can throw opioids at it all day long. Throwing opioids at a drug addict ain't gonna really do much for you. It's gonna piss you off, and it's probably gonna not help them. Or you could offer them a dental block, and I always do that. It kind of tells me, again, I'm not judging my patients how bad the pain is, and say, hey, I can make this better, and like right now you want to do a dental block? They're like, oh yeah, hell yeah, let's do it. And I'm like, all right, it's probably pretty bad. And they get instantaneous relief. That's pretty cool. What else for lidocaine and marking? Digital blocks, nerve blocks. Does anybody have like have like shoulder surgery or knee surgery or hand? Oh, what now? Was that you? Oh,
It wasn't on that note.
Okay, that's all right. Yeah. You can say whatever you want. Circle trust. Shoulder surgery? Did you do a nerve block on you? Yeah. Felt great, right? Totally good. Yeah. So I had a ACL, MCL, meniscal repair, and when was this? 2016, 2017, and they did a nerve block, femoral nerve block, and I was like, man, after surgery, I'm like, I feel great. I can go for a run. This is great. They're like, take your pain meds, don't be a hero. And I'm like, pain meds? I want to get addicted to this crap. I went home, and at like midnight, that nerve block wore off. And I swear, I looked down. I thought like a rat was just chewing on my leg. I started screaming. I was like, oh my God. It's too late. I'm already behind that pain curve. So nothing wrong with Jack Daniels in the face, but it's not the right answer. It's not the right answer. It's always the right answer. It's always the right answer. What's the difference between lidocaine and marcaine? Do you guys remember? Duration, onset, yeah. So if you're trying to get some good, fast, quick relief and make it last, just mix them. Can I mix them 50-50? Hell yeah. So, and you guys will carry this. I recommend you carry it in your aid bag. I probably use this 2-3 times a shift per ER shift, just blocking something or numbing something up, incision drainage, taking someone's something off, whatever. So, all right. Talked a little bit about Schwann cells. There you go. That's you, man. Yeah, I know. You love this stuff. So. And again, the myelin sheath, depending on how wrapped it is going to help us delineate how fast or slow that nerve signal is propagated. And then we'll talk about some pathology that kind of eats away at that myelin sheath and slows this down, okay? And that's going to be problematic, but we're usually not going to be able to look and see that. We're going to do a nerve conduction study or something like that. So a little bit more myelinated nerve cells, right? Voltage gate. You guys got this. You guys remember the nodes of Ranvier? Say it with a French accent, doesn't count. So. And then again, right, so this is going to result in increased speed, less energy, and then we talked, someone said in the back, Guillain-Barré syndrome is that demyelination or unwrapping of that. So usually, typically, with Guillain-Barré, your body's kind of attacking that myelin sheath, secondary to some other antibodies that you're already making. So we'll talk about that later. Bless you.
Thank you.
All right. We already know this. Neurotransmitters can be excitatory, inhibitory. Do you guys remember? So what's an inhibitory neurotransmitter from yesterday? GABA, right? So if we increase GABA, right, what happens to you? It's late, but I'm increasing it. You should get rowdy, right? No, you chill out. So it's inhibitor. You calm down. Just remember. All right, we already know this. We already said it. Chase it back to the anatomy. I should change it all, right? So where's the lesion? Identify the cause and treat it. So just chase it back to the lesion. Some other questions you can ask. Always stick with OPQ-RST, but check out your system. Is it motor, sensory, or both? Okay. What's the distribution of the weakness? Is it proximal, distal? Where's it starting? Is it in their hands and feet and working up, or is it working down? So just kind of think about some of those questions you might want to ask when you're investigating a neuropathy complaint. So, what else? Temporal evolution, fast, slow. Is this chronic? How long has it been going on for? Some things to think about, right? So we talked a little bit about carpal tunnel syndrome. Like, oh, I only notice this when I'm typing in my computer at iPad. Like, oh, that's interesting. So maybe that retinaculum is compressing the nerve. Or, you know, I've noticed this for the last 6 months. It's getting worse over the last month. You know, I started thinking like, maybe this could be a chronic disease pathology. Diabetes, right? Blame diabetes for everything. So. All right, we'll talk about some individual neuropathies. This is kind of a list of them. We'll kind of go through these as fast or slow as we need to. I'm not moving too fast. Now I feel like I'm just flying.
No, it's great.
No? I'm going to check with you first. Sir, am I good? I'm good? All right, thank you. All right, so your mononeuropathies, one nerve being compressed, right? This is secondary to direct trauma, compression, or entrapment, right? That's usually the cause of it. You can consider your electrodiagnostic studies, so looking for demyelination or axon degeneration, and you're going to get that through your EMG studies that you're going to send out or refer out to neurology to do that. So, and then if we catch it, so good news is somebody had carpal tunnel syndrome. Hopefully you got some treatment for it, saw somebody, and hopefully it got better. It might flare up, but this shouldn't be a permanent issue if we do our job and do our due diligence. So. All right, some common isolated peripheral neuropathies. You got facial Bell's palsy, so compression of that facial nerve causing paralysis on one side of the face. We'll talk about that a bunch a little bit later. Radial nerve, Saturday night palsy. It's called Saturday night palsy. Anybody know why? Because you fall asleep on a chair, right? Compressing the radial nerve, secondary from being too many adult amber colored beverages, I guess. I don't know. Just fall asleep and you compress that nerve. Median nerve, so carpal tunnel syndrome, ulnar, funny bone. Anybody ever smacked their funny bone? Anybody do it often? Yeah? How does that feel? It's kind of neat, I guess. It comes right back, so this is not permanent. But folks can have ulnar nerve compression up in this this groove here, which can cause that permanently, which that would be a little bit undesirable. So, and then lateral femoral cutaneous nerve impingement or neuralgia paresthetica, which we'll talk about in a second. So, radial neuropathy, compression of the radial nerve. This is that Saturday night palsy. So you get wrist drop, weakness on your thumb abduction, so thumb doesn't want to go out, and then finger extension. Fingers do not want to extend outwards. You get a sensory loss in the dorsal web space between your thumb and your index finger. It's right here. So this is, you got to ask your patient what's going on. So physically do your physical exam that you guys did last semester. Like open your fingers, right? Do this, do this, do that. You can't do that. Like, it's just impossible for them. So. And then you start, you do your whole bust out your sharp dull stuff, and they're not feeling anything right here. They got a loss of sensory nerve right between their thumb and their index finger. So. All right, most cases are going to resolve, right? You can splint them. There's a cock-up wrist splint. Cock-up meaning you're just going to put that wrist back. You don't have to do anything. They usually have removable splints. And then physical therapy can help them out as well. So our job is what? To find it. Yeah, right? So absolutely. To be astute enough to figure out what's going on, right? So when we're doing our physical exam and they're saying my hand's going numb, because they're never going to come in and say, I can't abduct my thumb, right? They're just going to be like, my hand is numb and I'm doing this all the time. So you're going to have to be the astute clinician and say, like, let me figure this out, and figure out which part of their hand is going on, and actually figure out that it's compression of that nerve. So typically, a wrist splint goes a long way. What's the problem with wrist splints? Compliance? Who wants to wear a wrist splint? I mean, how bad is it bothering you, right? So I try to tell my patients, if I find this, is I'll try to at least bargain with them, because I know they're not going to wear it. I'm just saying, just wear it at night. Wear it at night. So when they're flopping around at night, rolling around, they don't know what they're doing. They're compressing their wrists. They're doing all sorts of crazy stuff. Usually in the day, they're cognizant of it. Their brain is like turned on, and they're like, yeah, that sucks. I'm not going to do it. And then you guys will prescribe these out to them. You'll be giving wrist splints out to people all the time, and you'll see them doing their job, 3 to 5 meter rushes or whatever they're doing. motor pool Monday, no splints. And you're like, what am I doing? You're just fighting the good fight. Keep doing it. So. All right, carpal tunnel syndrome, compression of the median nerve at the wrist, that retinaculum here. It's a busy area. So things like Grand Central Station, things are going through here. Flexor extension tendons. You got some prominent vascularity going through there. Some nerves as well. So that retinaculum or that connective tissue can compress that, causing numbness, paresthesia in your thumb, index, middle, and half of your ring finger, right? So good luck having your patient say like, oh yeah, it's just half of this one. Like, I don't know, it's weird. They're not gonna tell you that. They're just gonna say it's my whole hand again. They're gonna be doing this, so. Aching pain, hand in the forearm, initially worse at night, shakes out their hand. They're always doing this to try to make it come alive again because it feels like it's dead, right? It's going to sleep. You get muscle weakness and atrophy in the thenar eminence. What's the thenar eminence? Yeah, this part right here. Right. So your thumb, the pad of your thumb. Tunnel sign. Anybody know Tunnel? Dr. Tunnel? Yeah, I don't know. This dude must have been like super with it, but just tap on it. You tap over the area and it elicits symptoms, right? So you can Tunnel this, you can Tunnel this, you can Tunnel whatever you want. Just make sure you give my man some credit. Phelan sign. Anybody know Phelan's? So wrists together, drop your elbows down, and you're just compressing that retinaculum. So you literally have your patients, like you can physically examine them and just tap over the nerve area in the retinaculum, see if you're getting any symptoms, or just press and hold. I don't know, tapping's kind of weird. It's like your typewriter in the wrist. Or you can just press and hold, a compression test, or just have them do it. Put your wrists together, drop your elbows down, and compress it. Then you'll stand there and you'll just talk to them for like 30 seconds, and eventually they'll start doing this. Like, what am I doing? They're like, oh, nothing. So tell me what you did over the weekend. And then all of a sudden they're like, yeah, something's weird. Like, you're like, okay, cool, hurting positive. But I'm just using that in my toolkit. So. And then that carpal compression test is literally just pressing over the area. So I don't know, maybe you guys come up with a name for it, put your name in there, get it published. But you guys will go over these tests a bunch, I think, in orthopedics. You haven't got it there yet, judging by the looks on your face. What the hell is he saying? I get that a lot, but more so right now. So. All right, imaging, so you can do an ultrasound if you need to. You can see some swelling in the median nerve if you're super hot with an ultrasound. I don't know that I've ever done that. You could refer them out for an ultrasound if you're concerned about it and take a look at the nerve. Diagnostic studies, that's going to be sensory delay before motor delay. So that's, again, sending them to neuro and having them put electricity through the nerve and taking a look at it. We're not doing that, but if you're concerned about it, let's say you're treating it, you split them, you do NSAIDs, you do activity mods, nothing's getting better. Maybe you're like, hey, maybe I'm missing something here. Maybe I would consider sending them for a EMG or a nerve conduction study, just to almost like prove to myself that I'm okay. There's nothing else there. So, but again, treatment, activity mod, NSAIDs, non-steroidals, a splint. You can inject that area, but I would caution you. Just we said there's a lot of activity in that area, so just be careful what you're injecting in the wrist. Typically, we try not to inject this side of the wrist. We'll leave that to orthopedics. This side, if you have a ganglion cyst or something, game on. But this side's a little bit, the stakes are a little bit higher. And then if they're not getting any better, you send them for an EMG and they confirm it, and you're like, listen, nothing's working. Send them to ortho. See if they want to do a surgical decompression, which is where they just cut that retinaculum. What's the problem with that? So we got that band of tissue compressing everything. Ortho's like, all right, man, I'm going to do it, but here's the risks and benefits. Like damage to surrounding structures, they coach you up, patient decides, screw this, I want to do it. They go in there and they cut that, they free that open in that space. It should be fine, right? Maybe you have some secondary tendon disruption, but what about scarring down when you go to heal? It's just going to scar, right? And potentially it could happen again. So talk to a lot of orthopedics. I'll stay out of that. It's not my lane. That's Major Dabalos. You guys have him next? You can ask him. See what he says. Orthopedic surgeons cut, so he'll probably be like, hell yeah. Do that 10 times out of 10. I just had a bunch say that it really doesn't bode well for the patient. So. All right, ulnar neuropathy, cubital tunnel syndrome. We already talked about that one up here in the cubital tunnel. If you guys, you could do a Tunnel on yourself. Everybody dare you, just go ahead. You guys, nice, like 3 people listening. So again, you don't have to smash your elbow into a desk to get that going. If you find the nerve and kind of, you can feel that groove and just tap it, and you'll eventually get some sort of elicitation of that paresthesia down your hands. And again, why do I tell you to do that? Otherwise, I just want to see if you actually do it. Is you can try to see. Can you see if it's half? If it's the median portion of your hand, half the 4th and 5th fingers? No. Like if you've ever smashed your elbow into something, it's your whole damn hand, right? So your patient's not going to be able to tell you that. And I guess that would be the takeaway from that. So pain at the elbow, forearm, and weakness, decreased sensation, and ulnar distribution, Tunnel sign at the elbow, and then Frohman sign. It's kind of one of these ones we don't see very often, but because of the numbness, when you go to hand somebody a piece of paper, they actually lose some of that dexterity, and instead of being able to pinch it, they kind of have to use the pads of their fingers. So I've never used that on a patient. Never, ever, ever. It's in the literature. All right, studies again. If you're not sure, again, this is kind of getting down that algorithm. You're like, hey, I don't know what's going on. I'm going to send it for a nerve conduction study. And just some slowing of that ulnar motor nerve conduction across the elbow, right? So if it's compressing it, it's kind of, it's I don't say strangulating it, but it's slowing its functionality down. You're going to see something with zapping it with some electricity. So. Ultrasound, sure, if you're good enough with it, you can see some swelling of the ulnar nerve around the elbow, and then treatment you guys can see there, same thing. Good luck getting people to wear elbow pads. Yes, sir. My bad, man.
No, you're good.
Yeah.
I lacerated my ulnar nerve.
Yeah.
In my hand,
Yeah.
And that's how they figured out was that numbness.
Did they really?
Yeah, so I couldn't do that.
Nice, dude.
I still
Yeah.
can't really do that.
Yeah, yeah. Did you have your hand up the whole time?
No.
Why don't you just say, like, say something? Yeah. Yeah. I feel bad. I saw you in my peripheral. I'm like, what? Yeah. Oh. And he points to you, and you're like, what? Yeah, cool story, right? So he couldn't do that. Frohman sign, so Frohman sign. It's pretty neat. Yeah, I just get so engulfed in this stuff. It's so jazzed up.
I didn't want to interrupt.
No, you have to. You have to. Do you mind me asking? How is it now?
It's still, it's like super specific, so that
Yeah.
half of the 4th finger down, and then the back side is fine. Long side's still numb.
Still numb?
Yeah,
That came back?
it's like super specific. But
Yeah.
It's, does its job.
How many does it job? I like it. I'm kind of attached to it. How long ago was it?
2019.
Okay, yeah, so you should have propagated most of your nerve function back then. Yeah. Good luck, man. You'll be all right. Ooh, she's screwed. No, I'm just kidding. I'm just kidding. You're fine. Yeah, it's funny. Like a couple surgeries that I've had. Like, if you've had surgery, you can appreciate this. Maybe not to that degree. Like when they fixed my knee, they cut through a lot of the superficial nerves, so everything's numb. I've got like an area of numbness. Same thing for that hernia repairs. Like I've got numb areas, and it's just weird. It's never fully come back, and it takes some time to get used to. But that's intense. Cool. Thank you for sharing. So lateral femoral cutaneous neuropathy. So this is neuralgia paresthetica. So where's that lateral femoral cutaneous nerve? Anybody remember? Yeah, up in your leg. So let's make sure everybody knows that. So common in obese, diabetic, pregnant patients, right? So you think about some, I don't know why, I think about my truck drivers have this all the time. So they get that big old pot belly and it's compressing that nerve. And it's so weird. 2 or 3 times that I've actually seen this, they come in and you look at them and you almost know, you don't want to jump to conclusions, but you look at them and they're like, yeah, my thigh right here is numb. And you're just like, holy cow. Like, did you just jump out of the textbook? Like, just get back in there, right? They almost look like they're like your pathognomonic patient. Pain, paresthesia, numbness in the lateral outer thigh. It's relieved with sitting because you're taking that pressure off. And then the imaging, you guys can see there. Treatment, weight loss, lidoderm patches. You can numb it up, but that's usually just going to take some of the pain away. Doesn't really fix the numbness and tingling area. So non-steroidals. And then neuropathic pain meds, don't memorize this, but there's a bunch of them you guys can use. Look it up. So gabapentin is there. Then you get into your second line, some of them like phenytoin. I'm not prescribing that to somebody with a numb, tingling upper thigh. I'm trying to think of some other ones. That's really hard to read anyway. So if I'm gonna ask you guys something specific out of this, I'll be sure to talk about it. And then for your pregnant patients, what's the treatment for them? Deliver the kid? Yeah. Yeah, it really stinks when you see that when they come in. And the good news is it's usually that third trimester. It's usually late, and you're like, I've got good news and bad news. Like, I know what's going on. Bad news is it's going to keep going on until you deliver this parasite. Excuse me? I mean, your kid. All right, some polyneuropathies, right? First, in generalities, first symptoms tend to be sensory. Usually it's symmetric, distal. So what do you guys think about when you hear this? Diabetes, hopefully. So like stocking glove distribution, numbness or tingling, hands and feet. So we'll get to it in a second. But B12 is another one, so that can cause it. So most animal products have this. So you think about it again, you're going to get this when you talk to your patient. So the dietary avoidance. Maybe if they tell you they have a history of pernicious anemia, that would be outstanding, but they're not going to say that. They're first going to tell you that they're vegetarians, right? Maybe they had gastric bypass surgery or inflammatory bowel disease, to include Crohn's or ulcerative colitis. So you just got to ask those questions if you're thinking about B12. Usually this comes up with my vegetarians, to be honest with you, but they're usually supplementing B12, usually pretty smart about it. Usually you see that distal symmetric numbness, gait instability, distal weakness. Usually your hands go first. And then you can also get diarrhea, glossitis, which is swelling of your tongue, and then anorexia, loss of appetite. So decreased vibratory sensation, hyperreflexia, absent, Achilles reflex, gait issues. Again, all this stuff kind of sounds like diabetes, but again, you would be able to ask them like any history of gastric bypass. Tell me about your diet. What are you eating? Oh, I'm a vegetarian, right? Okay. Oh, I have a history of pernicious anemia. Oh, I have ulcerative colitis or Crohn's. Those are things that we gotta ask these folks. Any vegetarians in here? I'm not throwing shade on you guys. Please don't take it that way. I wish I had the discipline to do that. Like all I can think about right now after talking about vegetarianism is just eating a freaking huge hanger steak. Like it's like a problem. It's a problem. All right. So if they're completed B12, what's the treatment? You guys killing it. So you guys are killing it. So, and it's actually it's a lot. So IM injections or oral dose, 1,000 micrograms a day orally. It's probably going to be the most economically advantageous treatment that the military will pay for anyways, but good. Cool. Mononeuropathy multiplex, this is going to refer to your diabetics, right? So we're just kind of labeling it right now. So there you go, diabetic neuropathy. Star this one for me, I'd like you to know this for sure. So diabetic neuropathy is the most common complication of diabetes, right? And I told you guys, I think last semester, it's sad, but these folks typically don't come in because of their hands and their feet. They come in for their genital dysfunction, right? So erectile dysfunction is what's going to cause them a lot of times to come and see you. That's a overgeneralization, but I feel like as soon as they lose that function, the alarms go off, and they're like, I gotta go get help. It's like, your foot's falling off too, sir. Like, it's all right. I got other things to worry about. So, diabetes is the most common cause of peripheral neuropathy in developed countries. You can star that. And then distal symmetric sensory and sensory motor polyneuropathy is the most common form of diabetic peripheral neuropathy. I don't know that I asked you guys that specific, but I definitely want us to know diabetic neuropathy. Risk factors, right? Long-standing, poorly controlled glucose levels or diabetes. So, what does it look like? Sensory involvement usually occurs first. That's stocking glove distribution. I said I hated those buzzwords, but there it is for you. So hands and feet. They get bilateral, symmetric, dulled perception of vibratory pain and temperature, and then the filament test. What's the filament test? You guys know?
The graphical, right? The grabbing the paper? Or?
No, that's filaments.
Oh,
So filaments, you guys will see these family medicine. The card? Yeah, with little strings, little fishing line in it. Yeah. Yep. And don't waste your time. I'm not going to ask you this. You don't have to memorize it. So when you go into your clinics, it'll be a little card that you'll pick up. You'll kind of bend it backwards, and it's got like a fishing line, like a high-test fishing line on there, and it'll have a picture of their foot and where you're supposed to poke them on their foot. So you're literally having them lay back, and you're poking their foot, different areas, to see if they can feel it or not. Sensitive and specific for diabetic neuropathy. And they say, like, all the time, you always want to check your diabetic's feet and their eyes, right? So always check their feet and their eyes. So if you're managing chronic diabetes, which I'll tell you, even when I was sitting here as a student, I'm like, this is stupid, I'm never going to have to deal with this. You're going to find diabetes on active duty, and then when you practice outside, oh my God, you're going to see diabetes. And if you're in San Antonio, you're definitely going to see diabetes. But these are things that we don't want to miss for them, because as soon as they start losing that sensation in their feet, that's when they start hitting them, they start getting ulcers, infections, and we start amputating. So, all right. So you get autonomic neuropathies as well. So vasomotor disturbances in the limbs, orthostatic hypotension, sweating disturbances. Why sweating disturbances? Exercise intolerance, dizziness. I'm gonna come back to it. Just finish the reading to you guys. I like reading out loud. So hypoglycemia, gastric apnea or gastroparesis, which is common, and bladder dysfunction or erectile dysfunction, which are it's the sweating disturbances because those small nerves control the sweat glands. Right? So they feel like they're either sweating too much or can't sweat. They just have no autonomic regulation of that anymore. So remember, diabetes is that C6H12O6 molecule. We need it, but too much of it is toxic to the small nerves. So start kind of crystallizing and breaking down that microvascular, those nerves, and our prominent or tiny little capillaries, venules, arterioles, and we start causing some issues for our folks. All right, treatment, tight glycemic control, fix that. Well, again, it's so easy. Why is it so hard? Compliance, 100%. Food's delicious. Yeah. Like, see San Antonio, right? If you're not from here, I'm not. I had no frame of reference when I got here, but the food is pretty damn good. I'm not gonna lie. Like, everywhere I go, people want me to eat stacks of tortillas. Who am I to say no? This should be rude, right? You can't say no. Sometimes you got to tell these folks that that's what's killing them. You got to push away. So everything in moderation. And again, this is going to be your guys' challenge. This is the challenge of the future, I think. And we're getting more aware of it. 500-pound patient comes in, the A1C is through the roof. Like, you don't want to scold them and reprimand them. Try to get realistic goals for them and work with them. Be an advocate for your patient. Hey, your A1C, which they're like, what is that? You're like, this is the level of your sugar constantly. Like, you can't cheat this anymore. It's really high. So let's work on it. Let's get it down 1 point in the next 30 days. And we'll keep going from there. So it's hard. It's hard. There's pain medications, so TCAs, gabapentin, SSRIs, SNRIs, capsaicin cream. Anybody know what capsaicin cream is? It's like, it's peppers. Like, it's, there's 2 peppers in it. It's slipping my mind. Doesn't matter, someone will have to look it up. But it has the Scoville unit of like a habanero, right? So you rub this on, and it elicits some of that substance P, those chemical mediators to that area, and helps kind of heal. I think, to me, someone gave me a tube of this once, and I put it on something. It really just distracts you. It's like the whole thing, and I don't know what, Juan will probably kill me for saying this. Like, we're going to talk about like the mechanism of action. Like, I don't know, it just burns like the Dickens. But you're like, oh, my hand hurts here a lot, and then you just punch somebody in the chest, and you're like, does your hand hurt anymore? And they're like, no, my chest hurts now. And you're like, but your hand doesn't hurt, right? So, like, that's what it felt like to me. And then you got to be careful telling your patients on some sensitive areas where you don't want to put this. Okay, where you don't want to put this. I'm talking about the eyeballs. I don't know what you guys are talking about. Your infantry guys, if there are prior infantry guys out there, I'm sorry, but if it's not a lubricant, it's not going to work for that. What I typically see is not that, is they'll put it on, they'll rub it on their hands, rub it on their whatever, their arm, and then later on they'll rub their eyes, and then their eyes start burning, and they come see you, and they're like, holy cow! And you're like, just flush them until you're tired, and then I'll continue to do it. So, all right. Neuropathies, we'll take a break in a couple minutes. So some other neuropathies, these are you know, this is a sequelae of the disease pathology itself. So HIV infections, 20% of your HIV infected patients will develop neuropathies from either disease or associated viral infections. You see there, number one is cytomegalovirus, or medications. Some of the antiviral regimens we have them on cause neuropathies as well. So put it in there just to tell you guys, like, if you're managing that, you may or may not see it on active duty. You won't be managing it probably for a long time. But you'll see it outpatient, and they usually come in with some sort of neuropathy as well. So, same for Lyme disease, right? You guys have already had infectious disease, right? You're taking it now? Oh, I knew that. So, I don't know if you talked about Lyme disease, but a spirochete, Borrelia burgdorferi. So, I've seen Lyme disease a couple times. Unfortunately, I didn't get the pathognomonic bullseye lesion. Like, strip you down, like, let's find it, right? It didn't work out that way. It was a little bit later, but this is going to be later in that disease pathology anyway. So that that bullseye lesion is usually early after they get bitten by the ticks. So the associated neuropathy, second, third stage of the infection, you can get a facial neuropathy, right? So usually bilateral in about half the cases. Unlike Bell's palsy. So a patient comes in and they're like, have Bell's palsy, but it looks like it's both sides. You're like, I don't know what this is. Just consider Lyme in your differential. So you guys can do your, again, I don't think you would do this like right away and be like, yeah, I think this is this. Let's do a EMG to check this out, but or biopsy something. But I'd say if you treat it and it's not getting better, it's something you consider obviously later on. It's like, hey, I've tried 2 or 3 things, this isn't getting better, let's look further explore, open our aperture on our differential. So. And then treatment, antibiotics wise, probably learning at this point, infectious disease, like bring some doxy, bring some Cipro wherever you go, and then figure out which one, or just throw them both at them. So. All right, zoster, right, so reactivation of chickenpox, so reactivation of HBZ presentation, you get that dermatonal pattern. These are great to find just based off physical exam. The patient comes in, I usually get a shingles or a zoster case like once or twice a month. It's usually your older folks, so their immune system's a little bit beat down. They just got a cold, they're sleeping like crap, their family's driving them nuts, so they're stressed out, and they come in and they got this painful rash. You look at it, and it's just vesicles on an erythematous base that does not cross midline. It actually just follows that dermatome nicely. And you're like, dude, this is shingles. Nothing else you have to do but treat it. So. You get that severe pain, paresthesias along the dermatome, and then you get that vesicular rash. You can see there you get a weakness in muscle corresponding to that dermatome in about 5 to 30% of the patients. And goals, promote rapid healing, lessen severity, so antivirals, right? So say 72 hours of clinical symptoms. If you're still seeing vesicles and they're still having pain, I would treat them. I wouldn't worry so much, like, oh, it's 73 hours, like, oh, we're outside the window. I usually, if I see it in shingles, they come see me, I'm gonna hit them with some acyclovir. I'm gonna give them some gabapentin for the nerve pain. And I'll probably give them some prednisone as well, just to kind of slow their immune system down, which are like, why would you do that? They just feel better, so. All right. A couple more. Hansen's disease or leprosy. Think we see this in the US at all?
Unlikely.
I don't know, yeah, I was like, so there used to be a little bit of history. It used to be pretty prominent. We used to have leper colonies. Anybody know which state, mostly? Hawaii? Maybe Hawaii.
Somewhere like
Louisiana? Anybody from the Lou? Yeah, for some reason, like, I don't know, look this up once. Texas had some, Louisiana had some. And, like, they would diagnose you with leprosy and be like, we have a nice place for you to go. And they used to have like a colony and like reproduce with leprosy. I'm like, that doesn't seem like it's a smart plan. US history.
Just surrounded by alligators.
But you can see there, so this is most common cause of peripheral neuropathy in Southeast Asia, Africa, and South America. So I think you guys might find yourself there ever. Maybe, if you're with Army South, AFRICOM, something like that. So just something to consider. What does it look like? Has anybody seen Braveheart? All right, who's not seen Braveheart the movie? Raise your hand high. Be proud of that. All right, your job this weekend, your homework, is to watch Braveheart. I don't think I can legally make you do that, to be honest. William Wallace needs you in his life. So, anyways, in the movie, Robert the Bruce's dad, if you guys, so for those that don't know what I'm talking about, I apologize up front. Robert the Bruce's dad, the guy that lived in the tower, he was a leper. And like, what was his characteristical findings? Of course, they were Hollywood, but like, what was happening to his face? Do you remember? What were we talking about? We're talking about kind of, let me get back into this, other disease processes that can manifest in neuropathies, right? So, not necessarily the hallmark of the disease. So we talked about leprosy, kind of having that characteristic of skin lesions, but that they will eventually develop a neuropathy. So that's why we're mentioning these ones. Okay, so we talked a little bit about recovery, and this is now we get into a little bit of your inherited neuropathies. So again, these are passed on from mom and dad. Charcot-Marie-Tooth disease, or CMT. We're really going to only talk about CMT1. See at the bottom of the slide there, it's the most common. It's like a 90-10 distribution. So CMT1 is really what you're going to see out there. This is going to be your most common type of hereditary neuropathy. So you can, I guess, underline that. It's the most common type. Like I said previously, like this is going to be several genetically distinct disorders, but they're going to have a neuropathy with it as well, which is why we're talking about it in neuro. So they're usually autosomal dominant. Does everybody remember what that means from your? You guys remember? Did you guys do like pungent charts and all that cool stuff? Was it fun? Yeah. Nice. Usually you're going to see this presenting as a foot or gait abnormality or foot drop, right? So foot drop being common. And what does that mean? What does that look like? Someone has a foot drop. Yeah, they're kind of like dragging their foot. They have this like kind of, again, I'm not saying they all do, but they'll have this kind of like walk, like their foot actually drops, right? So they're having trouble with their foot because it's going numb. And how do you figure that out as a clinician?
Watch more again.
You walk your patients, exactly, right? This is exactly why we all feel silly because we're all extremely healthy when you're downstairs. You're like, walk there, come back, walk on the balls of your feet, on the heels of your feet. You think they're gonna have problems doing this? Yeah, big time problems, right? They're not gonna be able to do it. So we see one or both feet are gonna be like, oh wow, something doesn't look right here. I don't know what it is, but I'm glad we did this exercise. So. All right, so this is going to be a slowly progressive neuropathy, or polyneuropathy, excuse me. Distal weakness, right, begins and then spreads, okay. Atrophy, so you get muscle wasting in the distal legs. They call it this inverted champagne bottle leg, right, so whatever the hell that means. So take a champagne bottle, put it upside down. So really what we're saying is the distal portion of the calf, or the lower extremity, you start losing muscle there first, okay. So you kind of see like skinny leg, and then you might see a little bit of a gastroc or soleus, a little bit higher than normal. So, like, wait a second, that's what my calf looks like. Don't worry, you don't have it. It's just if you're concerned about it and you see foot drop, and you're like, oh, your foot looks like an inverted champagne bottle, like bells should be going off in your head. You're never going to say that, ever going to say that to yourself. But if you ever got a question on your pants, or if I gave you a question and I throw inverted champagne bottle, I'm not going to just say, what disease is like classically found in it? That's just not fair. I'd give you a patient that came in, mom and dad passed something on, right? We're playing with the most common stuff. And I'll probably throw in there that they got distal weakness and their legs are atrophying. I wouldn't tell you it's an inverted champagne bottle. That's just cheating, right? Maybe I will. I don't know. We'll see how it feels. All right, depressed or absent DTRs, right? That's why we do them. So we check the patella, Achilles reflex. Treatment, no treatment is going to slow this. They got it. It's rare for patients to lose the ability to ambulate, and then they're going to benefit from PTOT, orthotics, right? So you're going to refer them out to kind of work, physical therapy, occupational therapy, and then also for the brace shop if we're not going to have those specific type of braces. If you guys are lucky enough to work at an MTF in the military, you'll probably have maybe some wrist splints, maybe some foot orthotic inserts that are trash. That's what you get, right? So you can refer them out. You just find ways to work around it, and you can send them out to the brake shop, and they can do more specific, higher functionality stuff for you. Okay. Let me see. Hereditary, sensory, and autonomic, are they very rare? We're just going to stop at that. So I'm not gonna go over this with you guys. Let me see if why is it in here? It's in your literature. HSAM1 most common. Tailor this for phase 2 if you see it. I've never recurrent osteomyelitis, gross foot and hand forms. I'm not going to ask you a question on that. If I do, I'll take it. All right. Familial amyloid polyneuropathy, right? So this is going to be caused by mutations of genes in transthyretin. It's the most common form. Classically presents insidious onset, numbness, painful paresthesia, early involvement in the autonomic nervous system. So we're going to get, so remember, what does your autonomic nervous system regulate? Heart rate. We talked about it yesterday.
Vitals.
Vitals, did I say? Yeah, so what did we say yesterday? It was your fight or flight? Did we say that? Yeah? Sympathetic, parasympathetic? Okay, good. I know, it was like yesterday, but, well, you know, that's not fair to you guys. Guess what I'm thinking is this is a crappy game when you're up there, right? You know, like, well, no, we don't know what you're saying, so. But again, this happens automatically, not autonomically, but I guess both. But so again, this is a systemic disease. You can see there at the bottom. Treatment may require liver transplant, right? So this is a serious disease process. So they may come in with some neuropathy as well. So if they have, again, if we don't ask them of their history or look in their history, they may have familial amyloidosis or something like that. So inherited neuropathies, Refsum's disease. This is autosomal recessive. Onset is infancy to early childhood. Circle that classic tetrad, right? So these are kind of fun to play with a little bit. You get your triads and tetrads, right? So peripheral neuropathy, retinitis pigmentosa, which is degeneration of the retina, right? So they slowly start to go blind. Cerebellar ataxia, and then elevated CSF protein concentrations. So that's kind of, we haven't talked about anything really that you start to get this numbness and tingling in your hands and feet. You can't see, you can't walk, and then eventually if they do ALP, they'll see elevated CSF. So you got to think Refsum's for that one, and that's usually in your kiddos. So. Diagnosis is made by elevated levels of phantanic acid, right? That's neat, but we're probably not going to be doing that. And then avoid dietary sources of that, and then also plasmapheresis to wash it out. Guillain-Barré, somebody mentioned earlier, so we'll get some questions on this one, but most common variant, acute inflammatory demyelinating polyradicular neuropathy, right? This is usually 1 to 3 weeks following an illness, 70% usually from GI and secondary to Campylobacter jejuni enteritis. So how do we figure that out? Is your patient going to say like, oh, got some numbness and tingling, I had Campylobacter like 3 weeks ago? Would be outstanding if they said that. Would be outstanding. But you have to ask their history, right? And it sucks because sometimes you have to reach in and pull it out specifically. Hey, like last month, did you have like explosive diarrhea, abdominal pain, like anything going on? They're like, yeah, you know what? That's funny you mentioned it. Like actually I did, right? You should start kind of being able to put that together. So this is immunologic demyelination of the peripheral nerves. So this is likely autoimmune. And this is an immune response to non-self antigens. So we're probably fighting Campylobacter, and some of those autoimmune response cells are just attacking our own cells, okay? Main complaint, variable weakness. Usually it's ascending paralysis, right? So usually the legs and ascends, paralysis, maximal by 2 weeks, about 90% by a month, and it's pretty quick, right? It can be hours to days that this is happening, so. DTRs are usually absent, areflexia, right? So I think that was highlighted for y'all. Yeah. So again, ascending, paralysis, areflexia. I want you guys to think recent history of GI-related issues. Let's think Guillain-Barré and our differential. Okay. Now, what's a concern with these folks? Like, great, you're coming into me. You have some numbness or tingling. It feels like it's starting your feet and it's moving upwards. It's ascending. Yeah, I'm like, man, were you sick? You're like, yeah, I had diarrhea. They told me I had a GI bug. I'm like, oh man, so this is kind of moving up on my differential. It's rapidly evolving. What's my concern? So it's slowly coming up here. Diver, right? So like, who's that? AI. So if it's rapidly evolving, we got to protect the muscles of respiration. So the diaphragm, right? So these folks, they come into you, and you just got to kind of think about it quickly. And again, this could be self-limiting. It could not go that way. It could stop in their legs and feet and then resolve. But if it's affecting their respiration, they could end up in the ICU with a tube as well. So, okay. Again, evaluation and treatment, afebrile, no other systemic symptoms, imaging, you're going to rule out all this other stuff, right? So typically you're going to make sure that they don't have meningitis or any other type of invasive tumor in their head that's causing this. You get down to the end and you're like, man, this could be Guillain-Barré. Nothing else is kind of making sense here. So CSF, high protein, normal cell count, nerve conduction studies you can see there. And then treatment, IVIG, plasmapheresis, plus or minus hospitalization, plus or minus ICU, plus or minus intubation. Big thing I think that's helpful for me when I see this is a lot of my neuropathies that I see on Saturday and Sunday, I'll hit them with a dose of steroids and they feel better, right? So I'll give them Solumedrol, I'll give them Decadron, I'll give them Toradol, I'll give them an NSAID and a steroid before I make sure it's safe, they don't have a history of GI bleeding, they're not pregnant, blah, blah, blah. But I give them that and I wait as I'm working them up, and then after I go check on them, they're like, yeah, I feel great. I don't know what you gave me, but it was a magic elixir. And I'm like, huh, it's called medication. That's how we win here. You come back to these patients, nothing. Like nothing, right? So you get all these histories, if you get all that history in your head, you're thinking, man, prior GI, ascending paralysis, I don't know what's going on here. Let me try something. Steroids do nothing. Like that should kind of, again, help you figure out your diagnosis of Guillain-Barré syndrome. I personally have never made this diagnosis. I've personally admitted folks for this without even knowing it. It's kind of embarrassing as your neurology instructor that I wasn't like, Guillain-Barré, I got it, nice, right? But I worked this person up that came in and I'm like, something doesn't feel right about this. CT non-con, CTA, labs, checked all their electrolytes, all their blood work, everything was normal. Steroids didn't help. LP was normal, right? And then I admitted to the floor because I'm like, I don't know what this person's doing, but they can't go home. And then the hospitalist was like, yeah, we need to get Neuro involved. It looks like rapidly evolving Guillain-Barré. And I'm like, son of a gun. Like, I gotta talk about that like next week. But that's okay, right? Sometimes, as I say, broke clocks right twice a day. And sometimes you just get the feeling like, obviously I can't, this person's sick, they can't go home. Can't put my finger on it, but they need to be in the hospital. So I'll let the specialist come down and say like, they'll pull out a piece of their hair, right? And they'll be like, it's Guillain-Barré, you're an idiot. I'm like, yeah, right? I don't know what I was doing, but thank God I didn't tell them to go home and drink water. So sometimes self-limiting, right? Usually most people make a full recovery, months to years. They may need rehab, right? So we got nerve involvement. So again, it can be variable how fast it comes back. They could have some minor areflexia, fatigue, persistent, and then mortality rate less than 5. That's not too bad, right? Unless you're at 5%, I guess. I don't know. Yeah. So it's there. It's definitely a consideration and something we need to think about. But all right, chronic inflammatory demyelinating polyneuropathy. I want you to take away, basically we'll talk about the highlighted stuff. So indistinguishable from Guillain-Barré. I want you to think of chronic Guillain-Barré that doesn't get better or it relapses and remits, comes back. Right? We need to just think about this. And I'm going to tell you truth in lending and be honest with y'all, you're probably not making this diagnosis, right? So you got somebody, like I just told you my case, they go to Neuro. Neuro's like, yeah, it's classic Guillain-Barré. You're like, damn it, I don't know why I didn't think of that. And then they come back a month later and they're having the same exact thing, right? They get in the hospital, get better, same exact thing. It keeps coming back. And you're like, something doesn't make sense here. Eventually somebody's going to probably think that this is chronic inflammatory demyelinating polyneuropathy, okay? All right. That's all I want to think about for that one. So yeah, you can see there your electrodiagnostics findings, they're going to be similar to Guillain-Barré. So I don't know if that's really going to help us too much. So We're not making the biopsy, we're not making the diagnosis based on that, but you're gonna see a little inflammation. This onion bulb changes, right, due to the recurrent demyelination. That's kind of neat, but pathology is gonna get super excited about that. So the mushrooms that are downstairs in the lab, no offense, that was terrible to say. So the folks that are downstairs in the lab in the dark, looking at all those things, that was really neat. They're gonna look at it and be like, oh, eureka, onion bulb. And you're gonna be like, what? Like, you're with the patients. That was me, and I shouldn't have said it. I almost caught it coming out of my mouth. But, and then the only other thing I'll say to this one is the response to steroids. So neat, right? So you can see there, is this response to glucocorticoids or steroids, whereas GBS does not. So that's neat. So I love pathologists. They're my favorite. Not really. All right, multiple myeloma. This is a bone disease. So this is this is a chronic systemic disease. Essentially, this is a cancer, a malignancy, but they're going to also have an overt polyneuropathy in about 5% of your patients. How are you going to know this? Right, so they were diagnosed with M&M, multiple myeloma, and maybe they come in and they wake up and have neuropathy now, something that we're probably going to see in a small amount of our patients with multiple myeloma. So just something to consider. But if you're making the diagnosis of M&M, those x-rays will show lytic, or like moth-eaten osteoporotic bone lesions are kind of pathognomonic for that. Your electrodiagnostic studies consistent with axon degeneration, okay, and usually it's a sensory motor, so you get both sensory and motor neuropathy. Okay, so the biggest problem is there multiple myeloma. That's what you need to treat. Hopefully that neuropathy will get better. So. Vasculitis, neuropathy. So what travels with our nerves? Artery and vein, right? Nerve, artery, vein. You guys probably got that anatomy. NAV, right? Nerve, artery, vein. So if we have inflammation of our arteries and veins, subsequently we can get vasculitic neuropathy. Okay. There's a bunch of them out there. We're just gonna touch on it again because it's a systemic disease pathology that can cause neuropathy. And again, this is what we're in neuro, so that's why we're talking about it. But inflammation of those arteries or veins, so polyarteria nodosa. There's Church-Strug. There's a bunch of other ones. It's not worth memorizing them. And again, this is going to be a long workup. This patient's going to have biopsies done to figure out that they have a vasculitis, and then you can kind of put it together and be like, oh, that's why they're having numbness and tingling as well. Is because they've got inflammation of the arterial walls in either their small, medium, or large arteries, depending on what you're dealing with. So. Yeah, that's a lot to say about nothing. So myasthenia gravis, this is one I'd like us to kind of pay a little bit more attention to. So it's a neuromuscular disorder characterized by weakness and fatigability of skeletal muscles, right? You're like, that sounds like me, right? So it's an autoimmune disease with a variable course, females greater than males. And our antibodies are targeting acetylcholine receptors, leading to decrease in the number of available receptors at a neuromuscular junction. So that whole thing we went over in the beginning of class about how acetylcholine works, that presynaptic cleft. Do we need to go back and talk about it again? Calcium, sodium. Does anybody want to do it? No? All right. So myasthenia gravis is autoimmune, and we're attacking that, right? So we're attacking those acetylcholine receptors. Which is going to create a problem for us. The hallmark features there, I would kind of look at the bottom of that when you're studying. Extraocular movements are affected first, right? So that's why we have them fix and follow. So they get a diplopia or a ptosis. They can get dysarthria, dysphagia, respiratory muscle weakness, generalized fluctuating weakness. Symptoms are worse towards the end of the day. And then symptoms typically improve with rest and first in the morning when they wake up. So. The exam, so they have an asymmetric ocular palsy and a ptosis. So what's wrong with my ladies out here? Yeah, she's got it down and out on her left, right? So she's got a ptosis, and she's got a ocular palsy there. So variable paresis or partial paralysis, normal sensation and reflexes, that's neat. And then muscle atrophy is going to be late. So testing, we can do acetylcholine receptor antibodies detected in the blood. And then our EMG nerve conduction studies are going to see impaired transmission. Something to remember with our myasthenia gravis patients, right? This is a classic board question. Never seen it, but I'm obligated to tell you about it. CT scan. So everybody remember the thymus gland?
What does that mean? What is your thymus gland do for you right now?
Nothing.
It shrivels up and just quits, right? It's like, I don't want to play anymore. So what happens is sometimes that thymus gland, that you get a thymoma, right? And these, you can get these anticholinergic receptor antibodies that secrete out of that thymus gland. So if we're thinking about this and we think it's myasthenia gravis, we need to check them out. We need to do a CT chest and make sure that they don't have a thymoma. And if they do, we send them to a surgeon and take it out, right? So make sure that those cells are actually atrophied and not creating a problem. Kind of neat, ice pack test, right? So we talked about that variable weakness, usually in the face, right? So you can go back to create that crazy eye that we just saw, that down and out palsy, or that diplopia or ptosis. You put an ice pack on that lady's eye and hold it there for about a minute and take it off and it's normal, right? Her eye goes back to normal, and then all of a sudden you're talking to her and the ice pack, kind of that coldness wears off and slows down and slowly goes outside. You're like, what? It's magic, it's witchcraft, right? You can do that bedside if you need to, and again, sensitivity, specificity, I don't have it for you off the top of my head, but I'd say it's just a pertinent positive, like in your mind, you're like, hey, let me see if this gets any better. Interesting. Like, if you have a case of this, I would absolutely try it. Tensilon test, this is probably more scientific. So administration of edrophonium, right? It's a short-acting cholinesterase inhibitor. So this is going to inhibit acetylcholine breakdown at the neuromuscular junction. That's our problem. So if we're inhibiting that breakdown, we do a quick test. It's getting better. That's again a firm positive. Probably more sensitive and specific than an ice pack on the face. I'd probably do both, but anyways. All right, so positive tests, definite improvement to weakness, right? Treatment options. So we're not here to memorize doses. You guys have enough to worry about with pharm. So anticholinergic drugs, proteostigmine, look up the dose. Thymectomy, so I would like us to know that. If we've got like a malfunctioning, proliferative, hypersecreting gland that should be shriveled up and not participating, let's get that out. And then steroids as well. So steroids can help. So if it's autoimmune and it's an autoimmune response, let's suppress the immune system a little bit and see if that helps. So again, we only talked about like one thing today, that steroids don't help. Do y'all remember what that was? Guillain-Barré, right? So again, just think about that as you guys go through this course in neurology. Damn near everything we talk about related to nerves and neurology, minus strokes and stuff. Obviously, don't give steroids to stroke patients, but we know that. So specific to neuropathy, steroids are going to be helpful, except for GBS, which I always found that was interesting. Plasmapheresis, right? So wash those antibodies, wash the blood out. But again, we're not doing that in our exam room. We're sending them to the lab for that. Myasthenic syndrome, or Lambert-Eaton. So this is associated with small cell carcinoma. This is the only thing we talk about, small cell carcinoma in this class. So defective release of acetylcholine in response to nerve impulses. Unlike myasthenia gravis, power steadily increases with sustained contraction. So myasthenia gravis is a fatigable syndrome, right? So these people get worse as the day goes on. So you think about it, you ask them to do like a Romberg test and they have myasthenia gravis. What do you think you're going to watch them? What's going to happen? They're just going to quit. They're just going to slowly right? This is kind of similar, but unlike that, they're going to get increased with sustained contraction. So EMG, treatment, steroids, right? So you're going to give them steroids as well. They're going to get better. And then the response to anticholinesterase medication is usually disappointing as opposed to myasthenia gravis. So a couple more. Bear with me. We're almost there. Botulism. So this is a toxin from Clostridium botulinum, right? This prevents the release of acetylcholine at the neuromuscular junction, right, and causes paralysis. Can be food or wound-borne, most commonly from canned foods. You'll get these questions on your pants. That's, baby comes in, is lifeless. Someone in the house was lifeless. They canned their own vegetables, and you're like, oh, whatever, I'll play the game. It's probably botulism. Weakness begins 12 to 72 hours after ingestion. You get double blurred vision. Another one with ptosis. I feel like everyone, usually their eyelids are gonna droop a little bit, but facial weakness, dysphagia, nasal speech, difficulty with respirations, and then your limb weakness is gonna be is the last sign. So again, kind of just I mentioned there a little bit, but considering a child less than 1 year who presents with constipation, poor feeding, and failure to thrive. Okay, so just consider with a kiddo less than 1, they may have been exposed to Clostridium botulinum. So what else do we use this for?
Botox.
Everybody says Botox is the greatest thing ever, right? Yeah, absolutely. What's that FDA approved for? Anybody know?
Headache?
Yeah, headaches and looking your best, right? Yeah, too bad. TRICARE won't pay for that. You guys will get credentialed or have the opportunity in family medicine to get credentialed to do Botox injections for headaches, and then like 7 out of the 10 patients that come in will be like, "Can you just do the forehead? Like, I don't want the rest of it." And I'm like, "It doesn't work that way. Sorry." Like, or you can take your business outside the RV and go do it on the street corner and make a whole lot of money. So, wait a second, let me back that up. Not literally. I mean, like in a building, credentialed. Not like, "Yo, I got Botox cheap," right? Don't do that. That's bad practice. That's bad practice. So. But if you do it and it's working, give me a call. I'm always up for it. I'm just kidding. All right. So the shorter the latent period to onset, so the quicker we find this, the better, right? So if they're exposed to Botox and it lasts a long time and we don't find it out till later, we're usually behind the power curve. So the more toxin that gets in the system, the later we're to the diagnosis, the worse this is going to be. So. Okay. You can do, usually the lab confirmation or confirmatory lab study will be serum or stool. And then initial management, like we talked about, muscles of respiration, so supportive care, right? So they need to be hospitalized, and then there's a botulism antitoxin. Do not memorize, look it up. So look it up. You guys can look this stuff up. You're not going to see this very often. It's going to be rare, and I would highly encourage you to try not to memorize everything through your medical course and just be like, "Holy cow, I think this is Botox. Let me go look something up real quick." So in the meantime, in the interim, if you think it's that and they're losing their airway, don't look up how to intubate somebody. Like, you need to do that promptly. Like, those are things like the 7 P's of RSI. Like, you guys are going to want to know those at the ER, like in the back of your hand, right? But like, if you're like, "What's the dose of Botox antivenom?" Like, I don't know that. So just go look it up. All right. Disorders associated with aminoglycoside use. So antibiotic stuff, right? So large doses of aminoglycoside, specifically gent and strep, so gentamicin and streptomycin, can present similar to botulism. So you guys just kind of circle those 2 meds, associate aminoglycosides. You have a patient. They were recently diagnosed with an infection, prescribed gent and strep. Now they're coming to you, they have difficulty breathing, they've got a droopy eye, stuff like that. We need to think this could be secondary to the medications that we've given them. So what's happening there prevents the release of acetylcholine from the nerve endings, right? You guys can see there. Stop the medication, get it out of the body, protect their airway, stuff like that. So. Yo, this man. Yeah.
Can you explain your
No, you get. Yeah, you guys will get it. I can't ruin it for you. Yeah. I'm sorry. That was rude to do, right? So, prepare, pre-oxygenate, pre-sedate, all that stuff. So when you go through taking someone's airway, there's certain algorithmic checks you want to do to make sure that you're successful. That's all I'll say on that. They don't want me to ruin emergency medicine for you guys. Yes. Your attitude is too cavalier. Like, this is a serious topic. I'm like, you can have fun and 2 things can be true at once. But anyways, back to this. Good question, though. Yeah. Maybe I'll do a OPD if you guys invite me on emergency medicine from my perspective. Yeah. I don't know. We'll see what happens. So, All right, tetanus or Clostridium tetani, so think lockjaw. This is why everybody in the ER, speaking of, with a wound gets a tetanus shot, right? This is why you guys are all up to date on your tetanus vaccination. This is why when people come to me and they've got stung by a nail or rusty metal and they're like, I don't know my tetanus, I'm like, you're getting one. We give them for free, right? Don't worry about it. So you get a tetanus, you get a tetanus shot, right? And we'll talk about why we do that because really the second and third effects of it of not treating this can be pretty nasty. So this is going to be toxin exposure from a contaminated wound, like we just talked about, right? Toxin binds irreversibly to receptor in the spine and brainstem, blocking the release of GABA. So we have no release of inhibitor, right? So we're no inhibition. So what's happening? Constant excitatory, right? So fatality rate is up to 60%. So we talked about one with 5%. I was like, that's not bad. This with 5%, 60%. Yikes. So now we're kind of creeping up here. Stakes are a little higher. All right. So incubates for about five days, 12 weeks, right? You can get trismus or lockjaw, right? So the patient comes into you and they're like, oh, what's going on, right? I had a good Lidwig's angina case. Did I tell you guys that? No? I think I told the other class. I had a lady that came in and I was like, is this tetanus? Like, what are you doing? Like, she came in and she had a dental infection. Like a week before, I checked her note. Well, she couldn't open her mouth. I said, let me open, take it, open wide, say ah. And she was like, oh. She was a skinny lady, like 30s. And then her face, like from her neck up, just looked like Jabba the Hutt. So I was like, what's going on with this lady? Like, one of the first questions I asked her is like, do you always look like this? Like, what type of question is that? I'm like, what's going on, man? What's bringing you in? She's like, what do you think? I'm like, I don't know. I've never met you before. Like, is this a normal look for you? She's like, no. I'm like, all right. Her whole neck, like her whole submandibular area, all the way up here too, was all swollen, extremely swollen. Couldn't give me a good history. Couldn't open her mouth. And she had basically biggest concern I had initially was ABCDs, right? So airway. Her airway's fine. It's patent. She's breathing, but I can't see any back there. And I don't want this to expeditiously become a RSI or a rapid sequence innovation. So I was like, all right, cool. She's maintaining her airway. Vitals are fine. Stats are fine. She's got an infection. Clearly, she's tachycardic. She's got a fever. Blood pressure was probably high because she's a San Antonian. Went back to her records and looked. She was prescribed Augmentin for a dental infection, periapical abscess, about a week ago. Supposed to follow up with dental, never did. Story I got was she went to dental that morning to fix it, and they were like, "No, go to the ER. Like something's wrong with you." So I saw her. I'm like, "Holy cow!" Pulled some labs on her. Really, I was like, "Let's watch that airway." Put her in the ER. I think I put her on a nasal cannula, even though she was doing fine. Gave her some pain meds, gave her some steroids. Steroids, right? Yeah, steroids. That's swollen, steroids. CBC, CMP, her white count was like north of 20. I think it was like 25. And then I got a lactic acid on her. Lactic acidosis was like 7, which that's just a breakdown in tissue. So she's got an infection, that's all I know. CT, I did a CT of the soft tissue throat because I'm like, I don't know what's wrong with you besides you look like Jabba the Hutt. So let's get a CT, and she had all sorts of air, neck fash, like all sorts of anaerobes producing air. I'll get you guys a CT. I think I have it in my phone somewhere, but maybe next class I'll show you. Neck fash, 3 planes, right? All 3 planes in the submandibular area were affected. So IV antibiotics, vancomycin. I had to transfer because we don't have ENT or OMFS, so I had to transfer to university, but she's going to need some debridement of that tissue as well. So anyways, has nothing to do with what we're talking about. Surprise, surprise. So we're back to tetanus. So lockjaw, that's a late finding. Dysphagia, laryngeal spasms, so those are going to be life-threatening. Facial muscle contortion, this rhizus sardonicus. Yeah, like your patients and again, I use my lady, I'll try to use her. She's sitting there going like this, and I'm like, open your mouth. And she's not. She's like, oh. I'm like, no, it's not working. Like, let me try a tongue blade. Maybe she's just not playing. Twist it in there, and it's like not, it's stuck. I'm like, damn, she got lockjaw? I'm like, that's interesting. If you're a patient sitting there and they're doing this, they're either pooping their pants or they've got like late stage tetanus, right? So something to consider. Painful spasming, right? So this is going to progress, ophthalminosis, right? So if you see them and their face is all contorted and then you leave and come back and they're doing a back bend like that, it's bad. It's a bad day. So, real talk, what could we do for this patient? So without looking, I think we talked about some of this stuff. If your patient has no inhibition or no inhibitor, no GABA, what did we talk about that works like GABA or increases? Benzos, right? So, right, if I see this, and again, we play in these, I joke with you guys, but if I see somebody doing a back bend or locked up or a dystonic reaction, you can hit them with some Ativan or something and see if they respond pretty quickly. So, have I seen somebody do the back bend like that? Never. I have not. So, but treatment, right? So tetanus, immunoglobulin, right? We already talked about tetanus boosters, clean debris the tissue, get that out of there. Metronidazole is going to help because that's going to target your Clostridium tetani. Heavy sedation with benzos for that muscle spasm, right? So we got no GABA. Let's increase some of that. Let's give you some benzodiazepines. So, mortality extremely high, so something that we have to consider. A little bit of nerve agent stuff. Cholinesterase inhibition. Acetylcholine does not get destroyed, right? So excess acetylcholine continues to stimulate, and we get organ overstimulation. So if you're exposed, you're out there. Again, we talk about this because obviously you guys were in the military, special population. But what is my platoon that just got exposed to nerve agent? What are they going to look like? Yeah. So all this like just salivation, lacrimation, defecation. You guys remember that? All that stuff from? Okay, good. And we have to have a high clinical suspicion, especially if we're in some foreign area, fighting some war or something like that, or maybe we're not, and somebody gets some unknown contamination, and they start coming to you at the aid station. Can't breathe, secretions, muscle spasming, unchecked acetylcholine, right? So just something you gotta think about. So. Good news is we got some treatments for it. You guys will have these in your sets, kits, and outfits. Just make sure they're current. That's all. We love sending folks to the Middle East, and then you'll get these threat briefs. They're like, we don't think they have it, but the most deadly course of action would be if they did and they used it. So we're going to have all this treatment. They'll give you the atropine, they'll give you the 2-pan chloride, and then they'll lock everything up. But just don't do that. Make sure you guys are giving it to the folks that need it. Would be my challenge to you. So, just a little history. 1955, right? Proteostigmine, bromine, approved treatment for myasthenia gravis, right? So what does this do? It hides or protects a fraction of acetylcholinesterase and creates reserve force. So if you have a higher clinical suspicion or operational threat, you can pre-treat with this stuff. Never done it, but it's out there. Something to consider. Work with your leadership, S2, if you think it could be helpful. So, in emergent measures, right? Supportive measures. These people come to you. They're inevitably going to come to your role 1 or role 2 because that's kind of the first and second stop in our medical evacuation system. Atropine, 2 milligrams, and then 2-pan chloride. So the good news is they usually come in antidote kits now. So the ATNA, or the antidote treatment nerve agent auto injector, or the CANA. Has anybody heard of these? Yeah. So, which is your, what's the CANA stand for? Something antidote nerve agent? What is it? Yeah, convulsive. Yeah, there's a word. So, convulsive antidote nerve agent. So, again, I took I didn't pay attention as much as I should have, but I took a CBRN treatment course, which is good. You guys should always do that. That'll be in my soapbox for that. If you guys can take short courses for a week, active duty folks and reserve and guard, go do it, right? So I was like, I didn't do something this year. What should I do? I went to Aberdeen Proving Ground and Dietrich, and I did a week-long course, CBRN treatment. And I remember these old dudes that were, they had forgotten more than I knew, right? So just super smart. And they were like, yeah, these people come into your aid station, just keep hitting them with these until they stop doing the funky trick. And I'm like, what? I'm like, wait, so what dose is that? And they're like, dude, you're not dosing anything at the roll 1. Like, you just keep stabbing them until they stop exhibiting symptoms. And I'm like, is this a real thing? Like, I hope I don't, maybe I hope I go to him, I don't know, but, I'll never forget that guy. It was funny. Anyways. Pralidoxime, right, protects acetylcholine from degradation, irreversibly binding by nerve agent, and then that's your 2-pan-chloride. So that's it. That's all. That's it. I just got off on another tangent. I almost took all the time. Holy cow! Really? You guys got to take a break. Oh yeah, take a break, and then I think you come back and have another class, right?
Sir,
Man, I lost track of time.
all day, every day.
Yeah.